Okay. Now, one of the things that has been a question, or used to be a question, I think we've answered it rather nicely now. The folks about to come up have answered it rather nicely. One of the questions that's been around for a while is, how well does DBT transfer from a research setting, from a highly controlled environment, to a practice setting? And so we're delighted to have with us folks from the evidence-based treatment centers. Am I getting it right? The name has changed, so I want to make sure I have it right. The evidence-based treatment centers here in Seattle. Unfortunately, Tony Dubose, who was going to make a piece of this presentation or lead it, is really sick and kind of retching as we speak, poor guy. So. But the good news is he has his team with him, well, they're not with him. His team is here, and so I have the pleasure to introduce Jennifer Sayers. Dr. Jennifer Sayers, actually, I've known since you were like 19, when she made the mistake of taking a class that I was teaching here at the University of Washington when I was a graduate student. So she's actually that old. She doesn't look it, but she is. And so Jennifer is a terrific therapist and supervisor. She's a reliable adherence coder and adherence supervision. She's provided supervision on multiple NIMH-funded research studies here in the BRTC. And she is currently the director of the DBT programs at the evidence-based treatment centers in Seattle. And I think probably the youngest person in the history of the universe to be ABEP, a master clinician. I think that might be true, actually. So it's my pleasure to introduce Jennifer to you, Dr. Jennifer Sayers.
Thank you. So yesterday morning, at the morning break, I checked my voicemail, and there was a message from Linda DeMeth, who is one of our speakers slated for this afternoon. And the message was, Linda is violently ill. She can't do her talk. Can you please do it for her? So I had this moment of, okay. I'm going to call up Tony Dubose, who also knows this talk, and we'll do this together. We'll figure out her slides. She's too sick to even talk us through her slides. I'm not sure what they all mean. Tony will help me. So I get a hold of Tony, and I say, Tony, Linda's really sick. Can we do her talk together? Because we can do this together. And he said, well, actually, I was on the airplane with Linda, and I am also violently ill, and could you do my talk too, please? So here I am. I am your substitute for the day. I am with you for a lot of the day. Thank you. I told them they both need to send me flowers. But actually, for this talk, the three of us are going to present this together. So we'll just pick up some of Tony's material as we go. First, I'll just introduce my colleagues here, and then I'm going to give you a little bit of history of our center. So I'll start with Micah Adler. Micah has, our center started in 2002, and Micah started with us in 2003. He was fresh out of psychology undergraduate here at University of Washington, came to work with us first as a volunteer, so he was just checking out, what is psychology like? Do I want to do this for a career? Moved into a paid position with more hours. And after a while, under our brilliant tutelage, realized he did not want to be a psychologist. So something we did or said. Luckily, he likes us a lot. He's still with us. But he decided to go into the business aspect of running a clinic. So he actually got his MBA along the way and is going to be talking to you about the business side of this endeavor. Something that I know a lot less about, and I rely on Micah heavily to teach me about that. And then we have Angela Davis, who is actually a postdoctoral fellow. We're going to be talking about our training program, and she will be talking about our quality assurance program and our research program. So she just started with us last fall, but this is her second postdoctoral fellowship. She was an undergraduate here as well. All three of us were. We were reminiscing about Kane Hall and all the things we've done in this room, like I saw a reggae band here. I took my SATs in this room. I think I had college-level sex ed in this room. This room has a lot of memories for me. So we were reminiscing a little bit earlier. But Angela was here as an undergrad, went to SUNY Albany, and became an outstanding behaviorist. I can vouch for that. She did her internship here again at University of Washington, and then her postdoc in David Barlow's lab, where she became an expert in CBT for eating disorders and CBT for anxiety disorders. So when she applied to our postdoc, I thought, wow, behaviorist who knows anxiety treatments, knows eating disorder treatments, I want this woman. And luckily she wanted us too. So she came to us for a second postdoc to become an expert in DBT so that she could treat eating disorders for very emotionally dysregulated individuals. So that's what we're focusing her training on. We'll talk more about the training aspect in a little bit. So I'm really glad you both are here. Okay, so I'm going to start. This first part is Tony's part, and he asked me to read you a little note from him, and then we'll just try to cover the material he wanted to cover. So he says, I was so very much looking forward to this conference, and am so disappointed to not be with you today. One of the most important points that I wanted to make in our presentation today was how strongly I believe that a solid and talented team is necessary for accomplishing the mission of the center, providing empirically supported treatments. This point is illustrated by the fact of my inability to attend and that my team has got me covered. I want to thank them for that. I also want to thank Perry Hoffman for organizing this event that I so wanted to attend. So he just asked that that be passed on. Impressive, he could write so coherently when he's so sick. Okay. So let me just give you a little history. Tony and I met, it was 1999. I was on internship and I was at Western State Hospital. And one of the rotations was the Child Study and Treatment Center, which some of you locals probably have heard of. This is where kids go. It's a forensic setting. It's where kids go when there's no other place to send them. So they've been to every inpatient unit. They've tried every treatment, and this is where they end up. And Tony was working very, very hard on setting up a DBT program for these kids in his cottage. So I wanted that rotation, of course. I'd been doing DBT for years in graduate school, and this was what I wanted. So I jumped on board Tony's team. And then the following year, I was a postdoc with Marcia Linehan, and she needed a skills leader. So I said, you've got to get Tony Dubose. So Tony and I have worked together a really long time. One of our favorite stories is how he went from my supervisor one year to the next year I was his boss. That was the best ever. I really enjoyed that. So we've worked together for a really long time, and toward the end of my postdoc, we started talking about, should we open up a DBT clinic? We really are passionate about the clinical work. This is what we want to do, and with a lot of help from Marcia. Marcia was a consultant and very helpful through that process. We, along with Beatrice Arambaru, who was one of the original students sitting around that table, Marcia mentioned yesterday, trying to figure out what this treatment was. She joined us, and a psychiatrist named David Lishner, who is trained by Kate Comtois. For many of you, those names won't be relevant, but Kate's speaking later, and she's an amazing, amazing trainer. So David was rock solid. So the four of us started a clinic in 2002. Micah joined us shortly thereafter, thank goodness. And then in 2005, I believe it was, we added one more person, Stacy Shaw Welch, as a founder of our centers. Stacy was also one of Marcia's students, but she did a postdoc with Barbara Rothbaum on anxiety treatments. And her dream was to continue doing DBT, but actually set up an anxiety program. This was pivotal for us. We were a DBT clinic. We were called the DBT Center of Seattle. And with the addition of Stacy, we became an evidence-based treatment center where we had more than one treatment to offer. And little did we know how that would really shake our worlds. It's very different to run a center with more than one treatment. We had to know the treatments. We had to know who we were targeting. We had to know all the research for each of these. So it was a very big transition for us. I think the main goal there was to make sure that we were scientists, practitioners. This was my dream all the way through graduate school. And, you know, this term gets dropped all the time. It's like the title of ABCT. It's in conferences, you hear this term scientist practitioner. But to actually do this and do this well is extremely difficult, and I did not expect that. So we were a private center. We were trying to deliver the best treatment possible, which meant we had to have time to see a lot of clients. We had to stay trained, so we had to be able to go to conferences, workshops, stay in touch with people who could teach us the best of the best. We wanted to be good consumers of research, which meant taking the time to do that and setting up structure within our centers to make sure all the clinicians are doing that. And we wanted to disseminate research. But we're a private clinic, so we don't get grants. We had to fight for a couple of years to get IRB approval. It's just been a long road with a lot of mistakes made and lessons learned how to make this clinic go. So as you'll see, we are now going strong. We've learned a lot, and it's almost 9 years later. But there have definitely been some bumps along the road that we're going to talk about today. Okay, so this is what we look like today. These are our programs. So we have the Dialectical Behavior Therapy Center of Seattle. Our clients and our colleagues want to kill us for all of the letters we have. So sorry. This is DBTCS, and ASRC is the Anxiety and Stress Reduction Center of Seattle. So that's the program that Stacy founded under our umbrella. We now have the Child and Adolescent Treatment Center of Seattle. And that treats children without anxiety disorders, or the anxiety disorder is not primary, adolescents, and then we do a lot of parent training as well. And we do all evidence-based treatment, so all of our clinicians are following the research very closely and using treatments that are cutting edge. Psychiatry Center of Seattle, we have 4 psychiatrists, 2 child and 2 adult. Our postdoctoral fellowship program, which I'll tell you more about in a little bit. And our consultation and practice management program, which so far has stayed fairly small, but I think we have plans to grow that, and Micah may talk a little bit about that. So this is us helping other clinics use evidence-based treatments, how to be savvy business-wise, how to do this, actually providing instruction to other clinics and solo practitioners. Okay, so Tony is saying that the big thing that was important to us early on is the team idea, and that we were trying to form a clinic based on these DBT principles of being direct with each other, being non-judgmental, really going with our values, thinking about what our values are and moving in accordance. So we were trying to use all these DBT treatment principles in our business meetings in how we developed this company. And that, of course, changed when we added another treatment that has different principles, different emphases. So we've really wrestled with how do we have an umbrella mission statement, how do we have a set of values that fits all of these different treatments and clients that we're now treating. So you'll hopefully hear about that as we go. Okay, I think that might be all. Well, one other point I'll make. This idea of an evidence-based clinic, it sounds so obvious, right? You learn a treatment that's research supported, and then you give it to your clients. It turns out that this doesn't happen very often. We have many, many clients come to us and say, I've had DBT, and they've learned one skills module, and that's it. But they believe they've gotten all of DBT. Or they come for OCD treatment and say, I've gotten treatment for OCD when they've had a little bit of cognitive therapy, maybe some relaxation training, never tried exposure. So the idea of getting this message across to clients, which I know is a mission of NEA BPD, of what is the full treatment, what is actually our best bet at helping you, how to get that across to clients and make sure that all of our therapists uphold that mission as well, has been really central to our company. Okay, I'm going to hand it off to Micah Adler at this point. I'll be back.
Thank you. Okay, so I'm going to cover a couple different slides for Tony as well, starting with Tony's transactional targets for business. this is something that I'm sure you guys have heard of in terms of transactional model, but at the top we look at it and we see that in order to be successful, you have to be profitable, especially within the private sector. What does this mean? This means that your revenue has to be greater than your expenses. In order for us to run any of the programs that we have, any of the quality assurance programs, any of the research programs, we need to be profitable at the end of the day, so it's something to be mindful of. On the bottom left, provide excellent client service. So this is something that we hold very dear to our hearts, in not only making sure that our clinicians are well versed in all aspects of the skills within the anxiety and stress reduction model, the DBT model, as we grow, maybe eating disorders model, but also the admin staff, making sure that the admin that are working within the clinic are actually not as well versed in terms of getting their PhDs, but actually understand and have read the books and have read the skills training modules to make sense of them and use them when interacting with clients. And then the third piece that's critical is maintaining a satisfying work environment. So making sure that we figure out a model for making sure that clinicians are paid at a level that they feel is reinforcing and acknowledging of their skill set, but also the admin staff as well, creating a model that admin can work through and see a pathway to grow. So that is Tony's transactional targets for business. If we take a step back, we need to think about when growing the practice or starting an evidence-based practice, who exactly is going to own this entity? Are you thinking about having a practice that's going to be separate tax ID numbers, where it's going to be essentially a whole bunch of combination of individual practitioners coming together, sharing a physical space, sharing admin, staff, and running operations that way? What would that look like? How would you actually roll out your billing in order to do that successfully? How would you have your staff trained in all the different aspects in terms of the individual entities that want things specifically their way? If you have 15 providers that have 15 different ways of doing their business, then it might be hard to actually run it successfully. The middle option is some of the group own it, and that is in line with the evidence-based treatment centers of Seattle in the sense that we have a partner group, and then under the partner group we have employees, fellows, admin staff, and so from the top portion most of the decisions are made and systematically rolled out to all the different layers of the organization. And then the last example is none. So this is provides a lot of freedom and autonomy and lack of structure in a lot of different ways, and is something to consider. So the dialectical dilemmas in an EBT business, these are things that we struggle with constantly, and there are things that actually structure our conversations when we're talking about the business entity, when we have business meetings about the practice on a regular basis. The first is profit versus altruism, meaning are we here to serve the population and make sure that we increase accessibility to mental health care, or are we here to make a profit? You know, which one trumps which one, and how do we figure out how to make a decision about which one is the highest priority? Interests of the individual versus interests of the company. This is essentially having the sensitivity to the needs of individual staff members and clients versus having the loyalty to the company. You know, which one is going to make sense for your specific practice is something to consider. Conformity to the institution versus individual autonomy. If you have 20 clinicians that come and join your evidence-based practice who are all rock stars, who all have a vision for how they want to roll out their practice and what they want to practice specifically, how do you figure out how to both fulfill and be sensitive to that individual need, but also, you know, have an understanding of what makes sense for the company as a whole? Also, interests of one group versus interests of another group. We see this every day at our practice, mostly in the sense of, you know, what argument or what conversation would trump what conversation when the admin is talking to clinical folks, when owners are talking to individual practitioners who aren't owners within the group. the needs of essentially one group versus another, and how to reconcile those differences on a regular basis. And finally, egalitarianism versus bureaucracy. Finding a balance that results in clear procedures and the needs of the company being met while each person in the company still feeling the company needs and being respectful to each other. So this is where I was supposed to start. So I am the Chief Operating Officer at the Evidence-Based Treatment Centers of Seattle, and I'll be mostly talking about running the practice from an administration and operations perspective, and what roadblocks we've experienced and how we've kind of navigated through those roadblocks in a way that has been very collaborative within our team structure. So my girlfriend and I recently got engaged. We had spent a significant amount of time together, and it became clear to us that, you know, we kind of had some similarities, and we were interested in kind of exploring the next step, and we realized that our value system was similar. We overlapped in our ideals, our thoughts in terms of how our family would want to be 10 to 15 years down the road, kind of matched on multiple levels. And we were ready to kind of take the next step, and we got engaged. Now, when I think about the engagement with my fiance, I think about the partnership at the Evidence-Based Treatment Centers of Seattle. I think about, and things to think about in the future for other people who are considering it, are, you know, the partners that you're thinking about growing an evidence-based practice with. Do you share a value system with your fellow colleagues? Do you have the same ideals in terms of where you want to be within that practice 10 to 15 years down the road? Do you have the same ideas in terms of your growth plan? Are you going to be creating something that's going to be scaling, or do you want to stop at a certain point because that's your kind of comfort zone? These are all things that the Evidence-Based Treatment Centers of Seattle has really, really wrestled with. And I think what helps define this in greater terms is what to do when there's conflict. Because if you don't have these conversations about your ideals and your values, when there's conflict, that conflict is going to be so much more difficult to mitigate if your values and ideals and thoughts of where you want to be 15 to 20 years down the road aren't aligned. So at EBT, we look at the values, our mission statement, and our strategic plan, and make sure that those things are aligned with the employees that are joining our practice, not only on the clinical level, but also on the administrative level as well. So I think about the strategic plan as three different buckets. We have the operating process, which is the day-to-day operations for running the practice. We have the personnel, which is our kind of general hiring plan. And then we have the financials, how to stay profitable, what things we need to look at to stay profitable on a regular basis. So under the processes for the clinical aspect, most of this is already defined because we're an evidence-based practice and the treatments are manualized, and there's not going to be too much deviation in terms of, from an operations perspective, how to roll those clinical treatments out. However, on the administrative side, we see that there's a significant amount of innovation and customization that's required. I went and got my MBA from the University of Washington and also did a number of classes in the MHA program here, and I realized that there's no model that has been created for an evidence-based practice. It's a little bit of a niche. It's growing, but there hasn't been it hasn't been something that business leaders have thought about and how to create successfully. So it's going to require a lot of innovation, a lot of customization, and a lot of things that business leaders within the evidence-based practice are going to have to wrestle with. So the operating process, a couple things that we've learned is a concept that I'm sure people in here have heard about but maybe not understood, and it's a concept known as opportunity cost. Opportunity cost to me, has been probably the thing that I've wrestled with the most within our entire practice, and something that Tony and I and David Lister and I, who's a CFO, have talked about on a regular basis throughout every single level of our business. Opportunity cost is essentially when you have two options, option A and option B, what value you lose in choosing option A, what value you lose by not choosing option B. So that can be discussed within every facet of the organization. For example, if you have a PhD or PsyD clinician or master's level clinician coming to your practice who is doing billing and participating in billing processes within your organization, or maybe doing some accounting work, or maybe doing some of their scheduling, what is the opportunity cost of them doing those processes and those procedures? What are we losing in terms of value, in terms of their billable time, revenue generating work for the practice, but also in terms of accessibility, in terms of mental health care services to the community? What are we losing by having those people do those kind of work, that kind of work for the organization? So we look at opportunity costs within every single level of the organization and think about it strategically about, if you make a decision, what are we losing as a result of making that decision? And how do we systematically look at that and understand it, and it's in our DNA to the point where we can make sense of it, and moving forward we can learn from it. A couple other things that we've discussed in the operating realm have been, and this is another Tony-ism, operations manual. There's nothing that excites Tony Dubose more than talking about his operations manual. And there's nothing that I've spent many hours with Tony talking about the operations manual. It's a beautiful piece of literature. It's about 111 pages, 9 chapters, everything from instructions about how to brew coffee to how to make sure that your skills training classes are being billed at the right CPT code in order to abide by insurance policies and procedures. But Tony has ingrained this in me in understanding that he always uses the concept of what happens if the people, the leaders of the organization, are all on a plane together and the plane goes down. What do you do? How do you make sense of that? Who's going to pick up? Here you have, right now we have over 550 clients at the evidence-based treatment centers of Seattle. If all the leaders of the organization go down in a plane, how are you going to pick up on Monday and make sure that the operations are still running smoothly, we're still able to provide the services that we have in a way that makes sense before we went down in a plane? So the operations manual is critical. It outlines every aspect of the business to make sure that the policies and procedures defend the business model that you've created. So you have a plan of where you want to be 5 to 10 years down the road, and the policies and procedures defend that model to help ensure success at the 5, 10, 15-year mark. Another aspect is technology. What is technology? Technology to our practice is everything. It's to have an electronic medical record and a system that is integrated fully with your scheduling, your billing, and your clinical documentation system, so you're not duplicating data and you're making every effort to eliminate the duplication of errors is very critical. And these are all kind of questions that we ask ourselves on a regular basis. How can we improve in these areas? How can we lower our administrative costs by having a fully integrated system that will allow us to have smooth operations? On the personnel, the clinical side, we've learned many things, as Jennifer was explaining. But on the clinical side, there's a concept that Jim Collins, the author of a business book called Good to Great, talked about this metaphor of a bus when hiring personnel. And it seems kind of trivial, the thought of this bus, but if you think about the bus being your company and making sure that you hire the right people that are aligned with your values, your mission, your principles, your ideals, where you want to be 10 to 15 years down the road. If you get the right people on that bus, and not only on the bus, but in the right seat on the bus, where, aka the right position within the company, then you can really drive it anywhere you want to go. And as long as the vision, as long as their ideals are overlapping and there's overlapping to the point where there's comfort with who the leaders of the organization are, when conflict again arises, that bus is going to keep moving. And so it means a lot to be able to have that. Now, once they're on the bus, there's a question of how to keep them on the bus. And we've experienced on several occasions questions of how to retain highly qualified clinicians and admin staff to create the model that we have from an operations perspective. And we've thrown around the idea of how to get them engaged with the community, how to make sure that they're compensated properly in terms of their salary, and also the thing that has probably surfaced the most frequently is, what is my pathway within your organization? How am I going to get to the next level, to the point where I can lead something, where I can direct something, where I can feel really a part of your mission? How can I get there, and how are you going to create that pathway for me? These are all things that we have wrestled with. So on the administration side, so I started actually at Marcia's lab in 2003 as a volunteer, and as Jennifer said, I moved to EBTCS as a volunteer, became administrative assistant, intake coordinator, so on and so forth. And what I realized in that experience is that there is a ton of excited, ambitious, eager to learn university, undergraduate psychology students that are looking for experiences all around the country. They are so passionate about the field. It's a very competitive field to get into. How do we create opportunities for them to grow within psychology? And so what we did is not only we built a pipeline directly from the University of Washington, not just because it's my alma mater, but because we realized that there's a significant number of passionate students from the university. But we built a pipeline and then created a model. We created a model where we recruited them through volunteer advertising, and now we have about 24 volunteers that have graduated from our 9-month internship program, and right now we have 8 volunteers that are working with us. From the volunteer pool, we hire administrative assistants that help with billing, operations, intake, all aspects of the system, but actually pay them an hourly wage. And then from the administrative assistant pool, we then hire the face of our company, our client services coordinators, who do all the intake and meet with every single client as they're coming in, address every single billing question. And it's created, this pipeline has been so successful because of the connection to the university, because of the connection to a group of highly ambitious, highly energized, passionate students from universities. And if you don't have a university around you, I would suggest recruiting from there, or there's colleges, there's community colleges, there's so much opportunity to be learned from this pipeline. Under the administration, there's also been a number of challenges. How do you provide excellent service to a very challenging population? I remember when I was the client services coordinator, a client called and asked me, or I explained a billing question at one point, and they responded by telling me they didn't know that the devil had a brother until they met me. And if I hadn't had Tony give me the DBT manual and DBT book and tell me that I had to read it from front to back and start quizzing me the day that I started my client services coordination position, had I not read all those things, I would have been ill-equipped to handle this comment. And so what we've learned, it's as important to hire clinicians that are excited about the skills and are qualified about the skills like Dr. Davis, it's as important to make sure that they understand it as it is the admin staff. Because the admin staff are the ones that are the face of the clinic. They interact with the clients when they call. They interact with the clients when they have questions about the most difficult aspects of the business, which is the money and the insurance and how to handle that and the struggles that go on with it. So we do role plays, and everybody reads literature to make sure that they're comfortable with the material, to make sense of it and know how to handle the questions as they arrive. So when somebody calls and says, I didn't know the devil had a brother until I met you, you know how to be compassionate and use validation and show empathy, take a non-judgmental stance, and be non-polarized in your response in a way that makes sense and accomplishes what you need. One of the interesting common themes in working with providers has been pretty consistent. It's been one of the biggest motivations for me to go and get my MBA at UW was that providers kept on saying, I had this really amazing clinical experience in terms of the clinical training that I got at my university or my institution. But the one thing that I never got was how to roll my skill set out into a model in terms of a business model. And so this is something to think about. What things do I need to think about if I want to start a practice? And what business concepts do I need to really get into my DNA, into my guts, to be able to understand it and make sense of it and utilize it on a regular basis? And so I outlined a couple here of things that I look at on a weekly basis or a monthly basis to make sure that the evidence-based practice that we have is clicking on all cylinders, is on a pathway for success 5, 10, 15 years down the road, and has a model that is sustainable and one that we're excited about. So KPIs, key performance indicators. This is some things that we look at on a regular basis. Profitability, obviously very, very important. The profit, revenue, very, very basic, but very, very important. Revenue minus expenses. You got to be profitable. The gross margin versus your operating expenses, things to think about in terms of if you have different programs like we do. If you're using certain models, how do you calculate what your revenue is? Your productivity times your fee per unit of service. And how does that look over the long term? Your gross margin for different programs, your expenses, and I kind of break down operating expenses based upon your operating expenses versus your clinical expenses, but the operating expenses include back office, which includes like insurance, staff, and billing staff versus front office, which is more client services coordination, people who are in the front office who interact with clients on a regular basis. And under the clinical expenses, clinical payroll, things like that. So these are areas to explore and what your KPIs might be if you're thinking about starting a practice, and how to monitor them on a regular basis and make necessary audibles along the way to make sure that you're in line with what your business model is, and doing it in a way that's systematic and rigorous and supportive. And, sorry, is Jennifer back?
Okay, Angela and I just committed. We're going to get us back on schedule. We started a little bit late. We're going to talk fast. We're going to do this. So, go team. Okay, so the reason I got nominated to do this portion of the talk is because I was the director of our training program for 7 years. I just stepped down last year to do the DBT program instead. And it's exciting to me and a little nerve-wracking. Both of my mentors are in the room, Marcia and Alan, and hope I do you proud, because this is the training program we've created. We started in 2003. We've had about 15 postdoctoral fellows go through our program since that time, so it's been busy. We take people who have just completed their PhD or their PsyD, or sometimes we get people much later in their career who want to go back for respecialization. That's fine too. But we've so far stuck with the doctoral level trainees, almost exclusively. We've had one master's level, and that's just for simplicity's sake. It becomes more complicated when we have different criteria we have to work with. So that's the only reason. Let's see here. Here's a look at what our job description is for a fellow. I just used DBT as an example. We actually have some that are pure anxiety or pure child fellows, but this is what a DBT fellow looks like. They take about 15 clients, both adults and adolescents. They run a skills training group. They do intakes with their own clients. They attend supervision, didactics. They go to our consultation team. They have administrative duties, and that's what Angela will describe next. And they also have the chance to join other treatment programs within our centers. So they might do some anxiety treatment and some DBT treatment, for example, which is a really nice opportunity for them. I think they enjoy the variety. This is what supervision looks like. So we do 2 hours per week, and I try to do 2 different supervisors. I think it's really, really important for them to see that one model of DBT is not all she wrote, that you can be 2 very different personalities, 2 different styles, and still be adherent in DBT. So I really want them to see that. So I might pair them with me, I'm the warm and cuddly one, and Beatrice, my colleague, who is very irreverent, very snappy, and we're both adherent in DBT. So I want them to see the comparison and know that they can find their own spot in providing DBT. We watch a lot of video, both in supervision and outside of supervision. The supervisors watch videos of sessions, do role-playing, modeling. We have formal didactics within supervision and outside of supervision, which I'll tell you about. Really focusing on case conceptualization. And live supervision is something we did a lot in Marcia's lab. She taught me how to do this, and now I'm finding it hard to keep it up. So the supervisor has to have an hour free to watch the session live, usually meet with the therapist before and after, and the client has to give consent. And that combination has been really hard for us to land on very frequently, but it's one of my goals to do more of that. I think it's remarkably helpful. Therapists get stuck and they don't quite know how to take what you say in supervision and actually do it in the room unless you just tell them live, and then they can just do what you say. So we're working on that one. So the other places we get training is consultation team. We have some very senior DBT clinicians in our team. Formal didactics, I try to send my fellows anywhere I can, to workshops, to classes, but we also do a lot of in-house training. I'm quite proud of our continuing education meetings. We've been approved by the APA to sponsor continuing education. We get guest speakers to come in. We meet once a week. And we also rotate this responsibility. So everyone who's licensed gets CE credit for coming to this meeting, and it's a wide variety of things from pharmacotherapy to HIPAA to ethics to suicide. It's been really a great program. Peer supervision. I'm convinced that our fellows love their peers more than their formal supervisors. They love peer supervision. I highly recommend it. And then the peer supervisor is still in supervision, so they get help about how to deliver this well. And then we provide a stipend for going to conferences and trainings. We're just trying to think of how do we build in things that will keep our standards high and keep the learning going. So we're trying to brainstorm this all the time. This is just a look at what our fellows do after they leave us. Go to all clinical, they go to research positions. We've had 3 now go to military positions, interestingly. The military is doing an overhaul, trying to get more evidence-based treatment in, so they are sucking up our clinicians. And then we suck up a lot of our clinicians. We hire them as staff. Very quickly, if you're going to get a fellow, think about where will you recruit, who will you recruit, when. If we recruit in the fall, we get very academic-heavy people who will interview at a conference. If we recruit in the summer, we get people who are not involved in the academic cycle at all and just want to get a new job or want specialization training. So it's very different who we get depending on when and where we recruit. You also might want to think about how many. It's lonely to be the only postdoc. but you get more than 1 or 2, and it's a lot of burden on the supervisors and the people running the program. So it's just something to consider. Okay, this is where I'll spend just a couple minutes, and then I'll wrap up. I just did a brainstorm of where do we get stuck? Where do we have trouble? Our fellows are not licensed when they come in. They can't be if they've just graduated. And then clients can't get reimbursed. So the clients say, I don't want a fellow because I can't get insurance reimbursement. So we have this fellow who's ready to learn, ready to go, and we can't assign clients. So how to get the therapist licensed as quickly as possible. That's been an issue for us. This all just takes money, people, time, energy, middle of the night worrying. I fulfill that piece. It's much more cost effective to just hire very experienced staff. So this has to be something you love to do. And we hit a point sometimes where I'm up at night thinking, okay, that person has that client's really high risk. Am I sure that therapist has everything they need? What about that next client? What about that next therapist? Are they happy? Are they burning out? So this just takes a lot of energy to keep going, and you've got to love it to make it worth it. I believe it's totally worth it. Teaching V6, so this is radical genuineness. So we get therapists straight out of graduate school who are taught if a client does something, drops the whole treatment plan and does something they promised they wouldn't do, the therapist will say, how does that make you feel? And how do you knock that out of them and get them to be real in session? Turns out that's a big challenge. So we do practice in supervision. I'll say, all right, what would you say to your brother if they did that? And they'd say, what the hell were you thinking? All right, practice that. I'm the client. Let's do it. So just teaching that is a big challenge, something that I run into quite a bit. Getting training in before they have their first session, this is much, much more successful if you know how to do commitment. If you don't know how to commitment, you can get yourself in trouble setting a precedent that's hard to get out of. Supervisors. Some of our supervisors are so accepting and warm and loving that they don't push for change enough. We actually need our therapists to learn quickly with these high-risk clients. Some of our supervisors are so heavy on change that the therapist is in tears and says, I just can't do this. So combining those two, just like you would in therapy, is a challenge. Power on team has been one of our biggest struggles. So how would you feel if you just graduated, you come into a team where you've got 3 BTech trainers, you've got people trained by Marshall Linehan, and you have an opinion. Do you say it? What if you think your supervisor is doing something wacky? Do you say it? No. So it's been a really big struggle for us to get them to speak up. It's hard, and I think we just have to let them get settled, push some, accept some, and let that evolve over time. Coordination between programs, context behavior in session, I'll just say very quickly. Another thing we've noticed that takes some time to learn. So what if you get your therapist to say, what the hell were you thinking? And they go into the next session and the client tears up for the very first time and they say, what the hell were you thinking? It's just what Katie was talking about yesterday. The context is so important, and when you're a new DBT therapist, you don't understand that yet. So really teaching when to use these strategies and when not to, and to not just follow the rules that the supervisor is giving you, but to actually do it based on context has been another challenge of ours. And lastly, I'll just say fear. I think fear is one of the hardest things to deal with. Our therapists, especially if they don't have a lot of experience with suicidal clients, are scared. So they may not do what you ask them to do in session because they think the client's going to die. So that's really difficult and something to talk about a lot. Okay, we're officially over time. We have 4 minutes for our last speaker. What should we do? Is that okay? Okay, I'm out of here. You can read the last slide.
Okay, so my name again is Angela Davis. I'm a licensed clinical fellow at the DBT Center within the Evidence-Based Treatment Centers of Seattle. I'm so excited to be here to talk to you about how it is that we go about evaluating the services that we provide. So this is something that's really unique about our program. Basically, we have a quality assurance or QA program And it's something that we officially launched in 2005 when we wanted to start evaluating client outcomes. Again, we think this is something really unique to our center. It's taken a lot of work to get it started, dedication to keep it going, and it's just something that we're really very proud of. And the reason we're so proud of this is that it really fits with our values of clinical excellence and science. So really with our values of giving clients the best treatment that we can. And we need to evaluate that on an ongoing basis to make sure that we're living true to that value. It's also related to our value of science, and particularly our value of the science of clinical psychology and our training as scientist practitioners, meaning that we think that treatment should inform research and research inform treatment. In support of these values, we have 3 primary goals to our program. The first is really to monitor our clients' progress. So we have the ability to monitor changes in target behaviors while we're administering treatment and then make treatment decisions or treatment changes based on the data that we get. And that's pretty cool. It also helps us with program evaluation. So at the program level, we can evaluate how it is that we're doing. So we say that we provide DBT. Are we really doing that? How effectively are we doing that? And then finally, our goal of research and really contributing to the literature of effectiveness research in real-world settings. So what does this look like, our assessment? Essentially, what happens is our assessment starts at intake. So clients come in, they have their initial intake where they will fill out some questionnaires. And then we track them, and they'll fill out the same set of questionnaires every 3 months, and then once more at termination. Our questionnaires are self-report. Some are clinician report. There's some teacher and parent report as well. They're brief, so in order to minimize the burden on our clients, we keep our measures limited to 15 questionnaires. And then the measures that we look for are hopefully free, validated, and commonly used in the treatment literature. So just to give you an example from our DBT program, or our adult DBT program, if someone came in, an adult looking for DBT, they'd be administered the OQ, or outcome questionnaire, the DERS, difficulty with emotion regulation scale, the BEST, borderline evaluation of symptoms over time. They would be given the suicidal behaviors questionnaire if they had any suicidal or self-harm behavior in a year prior to their intake. And then they'd get a skills training rating form, once completed by the therapist, once completed by the client, after their skills training starts. So again, we give up to 5 measures. So the first 3, the OQ, the DERS, and the BEST, are required in evaluating our DBT program. And then depending on what else the client might present with, we'll give them other measures, such as substance use, eating disorders, anger, impulsivity, anything else that we think would be helpful or that we think we'll be targeting in treatment. Okay, so how does this program work? Well, bottom line is it really takes a team. It takes a team of people who are dedicated to assessing outcome and who really value this. So it takes a team that starts with our front desk staff, our clients. They have to be willing to fill this out. The clinicians have to be willing to administer it. And then we actually have a QA team that's devoted to tracking this. So really, it starts at intake. If a client calls the front desk staff, they do a brief phone screen, they schedule an intake, and then once the intake is scheduled, they notify both the clinician the intake is scheduled with and the QA team, so we can start that our tracking or enter them into our database. The clinician, then based off the information that they receive from the brief phone screen, will go and actually pull the questionnaires that they think they're going to need. The front desk staff have to actually set aside or ask the client to come in a half an hour prior to their session to fill out this paperwork. They come in, they fill out the paperwork, hopefully the clinician can review it a little bit, go in, do their intake. The paperwork then goes into our QA mailbox where we enter it, and then we start tracking it and notifying clinicians every 3 months when their new QA is due for their client. We notify our clinicians 2 ways. The first way is that we send out an email once every week alerting them QA notification for week of, whatever it happens to be. And all their clients and when their QA is due is listed in that email. The second way is one of us on the QA team actually pulls the assessment measures for the clinician and then puts them in their mailbox so they can then give them to their clients. The last thing is termination. So it's important for the QA team to know when the client has been terminated. Otherwise, we just continue to harass the therapist to turn in their QA when the client is no longer in the center. So at termination, they are given their last set of QA. The clinician fills out a termination form, and then we can enter that into our system. Just to let you guys know some of the problems that we've encountered have really been keeping the clinicians motivated. We're a very busy clinic, and keeping already busy clinicians motivated to hand these assessment questionnaires to their clients can sometimes be challenging and require a few reminder emails. And some other things have just been the technology to support the tracking and the data storage. Measures is a real problem we've encountered, so we've really looked for free, valid, commonly used measures. However, some measures that we've wanted to use have required that we pay for them, and we've really had to decide which ones we were willing to pay for versus not. So for example, we were using the BDI, and that just started becoming too expensive, so we stopped. And if you think about it, you're paying for every questionnaire that's lost, that's, you know, not handed out, that just, yeah, whatever happens to it. On the other hand, the Achenbach measures we actually do pay for, so we paid for a site license for Achenbach, and that's fairly expensive, and yet we thought that it was worth it. Occasionally we get client resistance. They just don't want to fill it out. That actually hasn't been a big problem at our clinic. Getting meaning feedback to clinicians and clients on time. So that's one really nice part of our QA system is that we graph. So a UW volunteer will graph and enter the data into a database, and we can share that with our clients and track change over time. And then finally, just the staff to monitor the program and score the data. So things that have made our program successful, just real quick. Having the front desk schedule times for clients to come in and fill out their questionnaires. Sending clinician reminders. We couldn't do it without a QA team and really that A&R hours that the fellows put in. The UW volunteers, we use basic behavioral principles. So just about every month or every 2 months we have a QA superstar that actually gets a trophy that they can put in their office on their desk. An email goes out to all staff celebrating the new QA superstar. And then the other thing that makes it successful, again, is the graphing. So being able to see changes in your client and target behaviors over time and actually be able to review that with them. We're just getting ready to look at it. We have some data on 554 people in our DBT program. We've had 2 poster presentations so far, and we're working on the big challenge of transferring to an online system. So that's sort of where we are and where we're going.